Now let me invite Mr. Kiran Anandampillai, Advisor Technology, National Health Authority, Government of India. Again, Mr. Satish also talked about Ayushman Bharat Digital Mission. Yesterday, Dr. Arish Sharma talked about it. Let's hear from the man who is implementing technology for National Health Authority. A huge round of applause for him, please.
Good morning. Thank you and good morning, everyone. I think to start with, I have been actually, thank you, Satish, sir. I think I've been privileged to have worked on 3 at least of the programs you spoke about. So I've been part of the Aadhaar program. That was my first exposure to building technology at scale back in 2011. And subsequently, I've been working on technology for 2 large programs, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which provides health insurance cover to more than now 700 million people in this country. And the second program that got launched right in the middle of the COVID pandemic, the Ayushman Bharat Digital Mission. So my name is Kiran Anandampillai. I'm an advisor technology to the National Health Authority. One of the key, very interesting things, I think, so what I'm going to do in the next 10 minutes is just try to help you guys understand what is this Ayushman Bharat Digital Mission really all about. It's still a bit abstract. It has not had its UPI moment. So I think we are all at an age where we are very clear that just like the government has been building public goods like roads, this is the era of digital public infrastructure. And I think we have seen the power of what Aadhaar can do for your identity. We have seen the power of what UPI is doing as a digital public good for payments. But what are the digital public goods that a country needs to build for healthcare? So that's the question that we had to kind of go through. And what we are doing with the Ayushman Bharat Digital Mission is really the solutions to what are the digital public goods that a country should put together and how can it actually make a difference to citizens in terms of how healthcare is delivered. So I think in terms of when we think of health and healthcare and health information, I think I'm certain that it's rare for any of you in this room to have seen a diagnostic report recently that wasn't produced on a computer. It's almost always a printed report, right? So all of us got it. So if you got your COVID report, you probably got a PDF. I'm almost certain 99% of you would have seen your COVID test report on your phone first, and then maybe you got a Parchi bit later. While this is great that this is happening, there are 2 challenges with this right now. When does this clicker work? Okay, yeah. So first and foremost, if I ask you to fish out that last diagnostic report that you got from any lab, you may or may not be able to do it. So the fact that you're getting reports digitally, but it's not becoming part of your long-term health record, that's problem number 1. 2, every health institution produces reports in their own formats. It's great for doctors or humans to read, but it's not the best formats for machines to interpret. So those are the top 2 problems, and this is one of the things that the Ayushman Bharat Digital Mission is actually trying to solve. So all it says is, hey, Mr. Healthcare Provider, if you're creating a digital health data, can you start linking it to something we call as an Aadhaar? So don't just share it with the patient, but put a link to an Aadhaar. And 2, can you make sure that the digital format of the report uses a standard format called FHIR? So that's the 2 key things that we ask of healthcare providers. Of course, providers don't really need to do it. What it actually needs is a change in the software that the provider is using. So our program is more similar to what I can say as a BS4 or a BS5 car. None of us here care about what it takes to make a BS5 car, but we all hope to drive a BS4 or a BS5 car, right? So very similarly, that's what is going to be here. And if you think about what kind of health information we are targeting, the low-hanging fruit is really diagnostic reports and essentially pathology or imaging reports that are there. The next thing that we think will really get linked is discharge summaries, because there are medical, legal and other demands as to why it's being put together. What's going to be the hardest is actually your OP consultation notes and prescriptions, because that's a big change in behavior that you need to get out of your doctors, because doctors find it far easier to scribble the little prescription rather than actually having to adopt software. So as per the data that we have, out of over 1 million doctors, less than, only about 1 lakh doctors today use digital for the prescriptions and the OP consultation notes part. So it's still a long way to go on the digitization part. Immunization records are also going to be part of this. In fact, CoWINS has been now transformed to UWIN and will actually have universal immunization record. So all of us will have all of these. So India is actually starting very minimal. One of the problems actually the West faces today when it comes to health information is actually too much health information. So if you talk to a emergency care doctor who works in the US, he'll tell you that they're pouring through tons of data to figure out what is relevant. And that shift of digitization in the West was driven mostly by payers or insurance. India does not have similar drivers or pressures. And so we are also starting with a much more clearer view of saying, what's the minimal information we want to have which is useful in the delivery of care. Now, we said that the whole idea is that everything has to get linked to an ABA and the whole journey starts with an ABA. So where do you really get your ABA? So right now, all of you can get your ABA by either going to the website or by just using any of these apps. So just like in UPI, where you don't really think about what app you're using, whether you're using Google Pay or Paytm, when you go to a merchant, you scan, you make a payment. Very similarly in healthcare, we're looking to make sure that citizens have access to a whole choice of apps from the private sector and the ecosystem from which you can manage your health information. And we have about 5 apps already out there, including Arogya Setu, so you can all try it out if you haven't already done this. Get one of these apps, get yourself an ABHA. And if you, the mission is designed for people, including people without phones. There's a whole bunch of our population that still doesn't even carry a phone or just carries feature phones. So they can get their ABHA by just using an Aadhaar. So ABHAs are being issued at many public health facilities or as part of public health programs where you can actually get a physical card that essentially represents your ABHA. Now, how do you really use your ABHA? The most easiest way, so in this diagram, what you see in the middle are what we call as the digital public good. So the big digital public good that's part of healthcare, the first one that we're talking about today is called the Health Information Exchange and Consent Manager. So that's what enables this whole magic. Basically, once you get your ABHA, you can go to a hospital. So if you go to a public hospital, even here in MP and across many of India, you will now see a little QR code that's pasted at the counter. And you can actually just scan that QR code with any one of these apps. You're instantly registered at the hospital. And then whenever the hospital creates any new health record for you, it will link it automatically with your ABHA. You will get a nice little notification saying that, hey, you have a health record. You can actually see it immediately on your phone. So this experience is already live, running in over 500 to 600 public hospitals, including many here in MP and across the country. And that's how it works. So the key thing I want to talk about is that this whole architecture from a security and privacy perspective is what we call as a federated architecture. So it's not very different from you having a paper record. So let's say you had a paper health record today with you. You have a copy. You can show it to your doctor or you can show it to whoever you want. That's what you can do with it. It's exactly the same. The hospital or the clinic that creates the health record has a copy. You have a copy. And nobody else has it. So the government does not and cannot see what information you have in it. And you can decide who you want to share it with along with your consent. And this is an architecture that completely aligns with what we recently passed, the Data Protection Bill, very much in the Parliament just last week. So coming back to the digital public goods of the Ayushman Bharat Digital Mission, what I spoke to you about so far is just a tiny sliver of the work that the government is doing on the digital public goods. So we talked a bit about what's the interoperable health data. So how can we get everybody to get access to their own health data with personal health records? That's the first thing that this is doing. But the two other things that we are actually working on is also saying, how can we use this new network to create information that's useful for public health purposes? All of us saw, imagine how would anybody have managed the COVID pandemic if you couldn't tell where was the COVID test done, where was the positive, in which area it was, who was being impacted. It was not going to be possible to manage something like that without information flow that flowed in, which comes in. So very similarly, but for a whole wide range of diseases and for epidemic management, the mission is going to help. Plus, it's also going to help create a lot of data and anonymized data sets, which is very important in the world of AI. Apart from this, it's also working on a couple of other things. IRDA and NHA recently announced that almost all payers will have to adopt something called the Health Claims Exchange. So in India, if you run a hospital today, And if you ever go to a hospital with your insurance, you'll find that there's a big room called a TPA room. So depending on the insurance company's card that you say, they will say, okay, I will process it through this guy, because they'll say, for Star Health, please go to this portal and upload. For even Pradhan Mantri Jan Arogya Yojana, please go to XYZ and upload your information. And it's very, very difficult for hospitals to actually track and reconcile where their payments are. Also, because the large portion of the processes are not digital, it's very hard for the insurers to apply technologies like auto adjudication. So what the health claims exchange actually does is very simple. We have just standardized the claim insurance form into an e-claim document. So whether it's a public claim or a private claim, you can essentially create that with one single e-claim document. You take that e-claim document you create it in your own software that you use in the hospital, submit it to the health claims exchange. It gives you a transaction ID, and then you can track your claims all the way from its pre-auth till you get payment. Finally, the last area that ABDM is working on is digital health services. So think of today, if a doctor had to do a teleconsultation with a patient, both the doctor and the patient have to use the same platform, say Practo or an MFine. Both of them have to be on the same solution for the whole thing to work. What we are doing with UHI is saying, hey, the doctor can use any software they want, the patient can use any software they want. You can actually find the doctor, book an appointment, make a payment, exchange health records completely interoperably for things like teleconsultations or even booking an appointment with the doctor. So those are the digital public goods. Currently, the National Health Authority has taken the personal health records part live. There's already sandbox and integrations where developers can come in and build for the other two and are expected to go live shortly. And of course, compared to UPI, health is a very, very different ballgame. Imagine UPI, all of us enjoy UPI, but imagine if banks said, hey, I won't participate in UPI. So you couldn't really get UPI off the ground if you had refusal from banks. But banks had a strong regulator. You did not have too many banks to work with. Very, very different challenge here. We have 200,000 healthcare facilities. When we looked at what kind of people supply software to these guys, we found more than 2,000 people supply software. Not even one software vendor has even a 1% market share. So it's a highly fragmented market. And the challenge that's on us is to convince these software guys to come in, change their software, make their software ABDM compliant, go through a certification, then go back, roll that software into your hospitals, and only then can we actually get to this vision that we spoke about. So it's a very, very challenging and therefore going to be a long journey. We have managed to get about 100 out of these 2,000 guys, some really good names, big guys, to come in. And so the journey is kind of just starting. And there's a lot of what I call as tailwinds now coming. So as many of you might have seen, we just passed the data protection bill. The good part is data protection bill covers healthcare too, in the sense that if a clinic or a hospital is creating a health report which has our personal information of it, they will need to comply with the new bill that's coming up. The easiest way for them to comply will be to use an ABDM compliant software. So that's one of the tailwinds. Second, the National Health Authority is actually giving money for people to participate. 20 rupees for every health record linked right now under an incentive scheme. And I know several hospitals which are actually now, last month I saw somebody got about 3.2 lakhs worth of money for just participating in ABDM and actually linking these bills. So these are the tailwinds that are driving adoption, but we are still far away from the UPI moment. I think it's about 3 to 4 years before all of us will experience this, and hopefully there'll be big numbers back on the screen for what's going to happen. So this is the new digital highway, and we hope that we'll see significant participation and it'll touch all of your lives soon. Thank you.
Thank you, Kiran, for enlightening us about. Hi, I'm Abhijit, Managing Director, MP State Electronic Development Corporation. I had one question that I think we should also think of, like what we have health app in iPhones. On a personal data front, which is now almost like a metadata, can we do the analytics, which is a citizen-driven activity rather than a system-driven activity? So that the system is not reading the data, but I as a user am able to do a time series analysis of, say, my sugar levels, my LDL or HDL level, and I can get a suggested kind of a recipe, which is through an analytics engine, which is very well within the app. This is one of the a request probably. I had a word with Kiran sir also, and Abhishek is also happens to be my batchmate. So, secondly, what I feel for the faster adoption, if the state's government, because I'm not looking the whole thing from the IT perspective, if the state medical reimbursements can be made compulsory using ABHA, and if the state HRMS systems can be given an API for consumption of the data for validation, then it will have a very fast moving around of the whole scheme, because government is a major spender. And I was in finance, and almost 1,000 crore we spend on the medical reimbursement for government employees, right from say peon to the chief secretary. So, and third point probably, because I had been to a lot of hospitals and I say ki bhai abha aap kara do enter, bole I don't have the suit. So there needs to be a very high order of IAC probably in every state. I had a word with Kiran sir, he said ki they wanted to have a conference. So this digital good actually needs to be penetrated on a very fast scale. So probably engagement, multi-stakeholder engagement needs to be there, to start with faster adoption at the hospital level, especially for the private as well as the government. So in that case, probably, some stakeholder can be found out in the state, especially the software developers, who can very well implement the software very fast. So these are certain, suggestions. One is data analytics. Second is, making it compulsory for government employees for a medical claim reimbursement. And even we have got a CM Swekshanudan, wherein there is a CM discretionary fund which is of 500 crores every year. And that money is given directly to the hospital. So if that can be made compulsory, because these are certain admin decision only. I'm not trying to pose you. I'm just trying to that a push can come from the top. So these are certain points that
I think wonderful suggestion, sir, and I think absolutely right. The biggest challenge that we do face today is in terms of adoption. In fact, the best adoption that we have so far seen is from the public sector, and that's mainly because of the fact that in the government, it's far easier to push it with what I call as a stick approach. You can write letters from top down and get things to move. I think the struggle for us actually has been, given that the scheme when it started was, in the process said as completely voluntary, both for the provider and for the citizen. It has been really hard for us to find the drivers for adoption, especially in the private sector. So private sector adoption is still a big issue. So if you look at the overall numbers, you would find that almost 90% plus today is still with the public sector, and only about 10% is coming in from the private sector. But we are hoping that it will change. Like I said, the two things that are likely to be tailwinds are definitely going to be, one, the new data protection bill that just come out, and the incentive scheme is also starting to show good traction. So I think that will happen. The other part I did want to share with you was that the apps that I spoke about, all of them allow for users also to upload data which are part of their health record. So for example, if you have home devices where you're doing sugar or BP or other ways, so that's going to be able to come in. But I think we are still some distance away from good analytics of health data in India, like in what you see in the Apple, for a couple of reasons. The reports that say a lab generates, so a friend of mine actually works with data analytics with labs. So he pulls data from multiple labs. For a single test like cholesterol, there are 52 variants of names. And so India still hasn't fully adopted some of the standards to make some of the metrics happen. Well, that's one of the big pushes that we are trying to do with ABDM, but it is a slow journey. And even we have given concessions because we found many times that the vendors could not comply at the speed that we wanted. So it's like we phase it out and saying, okay, you start here, by next year you do this, and so on. So I think I would say if you look at the UPI journey or any of the other journeys, right? UPI, we wrote the specs in 2015. The first set of implementations were in 2016. If I go look at the first set of implementations in 2016, not one of them succeeded. Most of them were done by banks. The private sector and some implementations started coming out in 2017, but really 2019 is when the takeoff for UPI happened. I would say we are in the 2016-17 time frame for ABDM.
In fact, now it's a very high time, and like NHS should start TV commercials, to put it on the right public forefront.
In agreement, sir.
See, that's the beauty of this format. I must tell Mr. Anirudh Sharan Singh also, he talked about panel discussion. I said that it will be like interactive so that we can have both the sides' opinion here in the session. Thank you so much, Kiran Anandampillai, Advisor Technology, National Health Authority, Government of India, for a wonderful presentation. And it was, as you rightly said, a lot of things has been done, but a lot of things needs to be done. And as Mr. Abhijit Agarwal has also pointed out that this certain changes can be done. By the way, just to inform all of you, because some of you have joined today, Abhijit Agarwal is the Managing Director of MP State Electronic Development Corporation. He also happens to be the program chair of this conference. So, big round of applause for him as well, and his entire team. Thank you so much. Thank you so much.